With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. Glaucoma accounts for an estimated 12% of blindness in the U.S. In today's Part 2 glaucoma episode, we will discuss treatment, diagnosis, and prevention of glaucoma. Dr. Harvey Fishman, MD, Ph.D., Stanford-trained ophthalmologist, rejoins us to discuss. Dr. Fishman, thank you for joining me again.
Hey, Kerry, it's so great to see you. I miss hanging out with you all the time and doing our intellectual shows and having fun and so forth.
Well, I really appreciate it. In our first episode, we discussed what is glaucoma, the cause, the types, eye pressure, and even infantile glaucoma. But let's get started with today. Let's talk about how do we diagnose glaucoma?
Great question. So the thing about glaucoma, Kerry, is that as we mentioned in our previous show, it's one of these conditions that goes unnoticed a lot. And the reason being is that it generally doesn't cause pain, although one of the ways you can diagnose it, or one of those symptoms you can have, is pain for certain types of glaucoma. But generally it's a non-painful condition. And as a result, there is not, and because glaucoma tends to affect one eye and not the other, and also at least sequentially, it might affect one eye first but not the other. And because we have 2 eyes, that actually builds the visual field together. Our visual imagery of our world is, we have 2 eyes and they kind of mesh and they fill in details that are not picked up by one eye versus the other. And as a result, we tend not to go in for if we don't have symptoms, we don't go into the eye doctor. And so the problem is that, we often will have some people will have glaucoma and never know it. So the way it's diagnosed is, number one, it's like what I said before, which is you don't know what you don't know. You got to go into the optometrist or ophthalmologist to get particular exams to diagnose it. And the way it's diagnosed is, and this will surprise people who are not familiar with, the basic definition of glaucoma, it's not necessarily pressure. In fact, if you're a really, really good glaucoma specialist, you actually look at the optic nerve, because glaucoma, as we mentioned in our previous show, is a disease of the optic nerve. While pressure and these other, things that you see are risk factors for glaucoma, it doesn't define glaucoma. Pressure doesn't define glaucoma. Again, it's like that previous analogy. I guess I shouldn't say that it's the spaghetti, the spaghetti strands, or the very delicate threads, which is the optic nerve. But really, the diagnosis comes in studying and understanding that very delicate structure of the optic nerve. I was going to say it's angel hair pasta, but somehow I can't get angel hair pasta. Maybe I'm really excited about Italian food tonight or something. But the angel hair pasta analogy, it's probably more like, just as I said, gossamer thread of a bunch of fibers. And so when you go into the optometrist or ophthalmologist, their goal is to actually look at that and actually visualize that optic nerve and to see if there's actually damage. So it's like a little micro break break in that thread, or some of those threads, the gossamer threads, which are the analogy of what your optic nerve is. The other way you can think of your optic nerve is a coax cable from the back of your eye to your brain. And so the way it's diagnosed is to try to figure out is there any damage to that coax cable? Is there any damage to this bundle of threads that are connecting your eye to your brain? And it's not necessarily it is not a trivial task. It can be, in some cases, it can be like very, classic. In other cases, it can't. So the first thing that we look at when we make a diagnosis of glaucoma is we actually look at the optic nerve. And if you're really skilled in looking at the optic nerve, you can look at certain telltale signs of the structure. You can actually see the optic nerve almost like going away, like I was going to say melting away, but it's like tissue. It's like atrophy. One of the things that you see when you look at a healthy optic nerve is you see a nice, robust optic nerve where when we look at it, there's a nice rim of tissue. And this rim of tissue, when the doctor looks at it, can be described as like what's called the cup to disc ratio. But the reality is that when you look at that rim of tissue, there's an observation. You can sort of get you can look at the color of it. You can look at whether there's some atrophy, meaning is there parts of the optic nerve that have sort of gone away. So that's the first thing you do. You just actually look at it. And all great glaucoma specialists are just expert at actually looking at the optic nerve. But over the years, we've found that, if you take a bunch of glaucoma specialists and you compare their abilities or you compare their observations of optic nerve appearance, it actually turns out to be there's a lot of variability. It's kind of like taking 10 economists and putting them in a room and you come out with 10 different ideas. It's true, glaucoma, and that's the challenge, is that, one glaucoma specialist or a glaucoma person may look at an optic nerve and say, this looks very suspicious. Another one might say, yeah, I don't think it's that's much of a difference. Sometimes it's a clear-cut thing, sometimes it isn't. So the reason that there's that disparity in terms of actually looking at the optic nerve and sort of documenting and taking pictures of it is so the idea is that based on that initial exam that you do, you may get a sense that this is a suspicious nerve or not. Sometimes you just know it is, or it's a glaucoma nerve, and the diagnosis is there. However, other times, and most of the time, and the way we describe glaucoma, it's actually a change. So you can be born, or you can have an optic nerve that's damaged or atrophied or gone from the start, from birth or from whatever happens in life. But really, glaucoma is defined as a change. It's not just damage to the optic nerve, but it's progression. It's progressive damage and progressive loss. So really, the second aspect of diagnosing it is actually when you look at it. I'm going to get to some of the more sophisticated techniques we have, but just showing there's change and there's an ongoing change and ongoing loss of that nerve tissue. So that's a critical aspect of defining glaucoma, because if there's no change, then it's not an active progressive glaucomatous damage or occurring, and that has something to do about your condition. So it's not just, so you document it, you look at it, and you look at it from year to year, which again gets back to you need to go in on multiple visits, because you can't know if you don't know what you don't know, and you don't know if the glaucoma is progressing. So that's just like sort of traditional and standard way that we've always diagnosed glaucoma. But then in the last couple of years, we've developed some incredibly sophisticated tools, imaging techniques, in particular optical coherence tomography, which is basically a technique that actually looks at the thickness of the nerve. So we can actually scan we can scan the nerve with light, that non-invasive light, so to speak, that actually basically gives you a volumetric, an entire image of the optic nerve, not only like the rim of the nerve, but you can look at the thickness of the nerve, and you can look at what the topography, you can look at what the shape of the nerve is, and you can look at it in different depths and different levels. And so there are these techniques with OCT where you can actually start looking actually at the thickness of the nerve. And then again, when that gives you an ability to really understand, is there actual loss of nerve tissue or isn't there? And then these devices also can look at progressive changes. So you can see, like on year one, you may have this amount of nerve tissue, the threads, the bundle, the coax cable, and then you might notice that in future visits, that coax cable gets smaller and smaller, it gets thinner and thinner, and then there's less tissue. And that, of course, goes back to your observation, like we said, that you might notice changes. So that's the second way, this OCT imaging. And there are new and up and coming imaging techniques all the time. That OCT can also image different parts of the retina, which also reflect, which is where where the optic nerve actually starts. The optic nerve, the tissue of the optic nerve actually starts in the retina. And so you can actually look at the retina. And then the other technique, so the third technique that we do after observation and after using OCT, is we use one of the gold standards, which is actually a visual field. You can have a decrease in tissue, but you have a totally normal vision. One of the great things about our visual system is there's a lot of redundancy. So our visual system was built with this redundancy in place so that you can lose a lot of tissue and still function completely normally. So the next thing we look at is we actually do which is called a visual field. And again, that's a test. It's kind of a frustrating test, and everybody hates it. But what it does is you cover up each eye and you test each eye, and and what happens in this test is that little light shines up, little light flashes, and then you're looking straight ahead, and it just basically probes your visual field. And the thing that's interesting about that is, first of all, you're doing each eye individually, which most people don't do in their daily lives. And as I mentioned in our previous discussion, many people can have vision loss, and actually significant vision loss in one eye, because they just gradually stop using that eye. And then weird things happen, like they cover up that eye, and all of a sudden, or they cover up their good eye, and then all of a sudden they realize, hey, I can't see. So the third thing is this visual field, and those are the standard ways that we diagnose it. Now, pressure we also measure the eye pressure, which tells us something about the risk factor. If the eye pressure is really high, again, it doesn't define glaucoma, because again, glaucoma is damage to the optic nerve, but it does give us more information about knowing whether or not that this is glaucoma. Obviously, we ask really specific questions, like we ask family history, and we go through all your risk factors, and that helps us make a diagnosis of it in terms of like giving us more confidence that if everybody in your family has glaucoma and your pressure is elevated and your visual field shows the defects in the vision that are consistent with glaucoma, and your OCT looks like it's thinned out, then it's probably glaucoma. But there's a lot of masquerading diseases that can mimic glaucoma, and that's something that's really important to consider as well. And if you have a really skilled glaucoma specialist or someone who does a lot of glaucoma, they can often tease apart what might look like glaucoma but could actually be brain tumor. And that's one of the big pitfalls of glaucoma diagnosis, is sometimes you can have brain tumors that actually mimic glaucoma, and you got to be very careful. And then, of course, there are types of glaucoma that you're born with. And so good family history and good documentation over many years helps you know whether this was a congenital, meaning you were born with this type of damage to the optic nerve versus not. So it's really it's a very fascinating field. And the other thing, some of the newer imaging techniques to diagnose it are now including things like looking not just at the structure of the nerve, but actually the vasculature. So people have found that the blood vessels that supply the optic nerve, they also drop out. And so by looking at the vasculature with some of our new techniques, a different type of OCT, which you and I actually happen to have, to look at the vasculature, that's also something that's really helpful. So those are the main techniques that we're using. And I think that we're going to be seeing more and more advancements in those areas in the next couple of years.
What's interesting is that if somebody has significant nerve damage, it's really easy to make the diagnosis. But when it's difficult is those people that may have glaucoma or may not have glaucoma. And we know that people have glaucoma, there's about a 40% chance they could lose vision in one of the eyes. So we want to diagnose as soon as possible so we could treat early. So yeah, it's very easy when there's something significantly wrong and we have a beautiful visual field defect and we see that notch. But those borderline cases when we have one of the risk factors that are high, but we're not sure whether or not to treat those people. When you're not sure and you're on the fence and you're looking and the imaging, the OCT is kind of borderline. And something, the corneal thickness that we didn't talk about yet, the corneal thickness is maybe thinner, and that's a risk factor. We'll use an ultrasound and we'll measure the front of the eye and check for the corneal thickness. And those cases where we don't want to overtreat anybody, but of course we don't want to undertreat either, because the results could be devastating. How do you handle that?
Where it's a borderline case.
Yeah.
I mean, those are the difficult cases. I mean, the most important thing about those borderline cases is, if number one, to follow them, because the disease will often manifest itself. And so if you diagnose somebody as a so-called glaucoma suspect, the key is just making sure that that follow-up occurs, either by you or by other people. And the other thing is, you have to have a good understanding with the patient. The patient needs to know you got to tell them about the big picture, that this is a risk factor for glaucoma. It doesn't necessarily mean you have glaucoma, but you need to be followed, and you need to have your nerve checked, and all these things that we talked about in the past. And so for patients who have, for the risk factor, you can kind of present to them the way I deal with it is, like, I present to them, I try to teach as much as I can about what the process is, and the fact, what are the risks and what are the benefits or the risks or the downside of treating without actually knowing 100% that this is actually glaucoma or not. And I think that, at least in my practice, what I try to do is I try to have a really, transparent conversation, saying, this to me looks like you have glaucoma. It has all the features of glaucoma. You haven't maybe manifested it yet. And then so in those patients, we kind of have a really honest conversation. Do you want to take a drop, which you might have to take for the rest of your life starting now, that might protect you from getting this? And with the very possibility that we're, quote unquote, I wouldn't exactly call it over treating, but you could use you could use a term like, we're being preventative. It's kind of like, if you have somebody who has heart disease, if you have a family history of heart disease and the person's cholesterol is high, do you give them anti-cholesterol medicine? Do you give them Lipitor? Do you give them these different medicines, even though they don't necessarily have any disease at that point? Same kind of discussion. If somebody has high blood pressure, same thing. If somebody comes in with high blood pressure, internists and family, we're as physicians, we tend to treat that, because we know that that's a risk factor for getting heart disease and strokes and so forth. And it's exactly the same conversation with somebody who's a glaucoma suspect. You look at the nerve and you say, hey, this looks like it could be glaucoma. I'm not 100% sure, and I'll mention what other techniques that I do, but or things like other things that I do. But the other thing I would say is, like, you say, okay, hey, this is, we can treat you with this drug this eye drop that's going to lower the pressure. The side effects of eye drops are not necessarily devastating. It's not going to, usually they're not going to blind you, or they're not going to cause other problems from the side effects of the drops. Usually, worst case scenarios, they can irritate your eye. Generally, and that's not, and it can also cause color changes to the color of your eye, and it can cause your skin to get, have some changes because of the drops that we use. So they're not 100%, without side effects, but, neither are cholesterol drugs or pressure, or blood pressure drugs. And so you have this conversation where you say this, this is what we might do. And the other thing is, I think you have to basically say, if there's some question about whether you should take the drop or not, you can always say, well, we can follow you really carefully. We can do more frequent visits, because if there's any changes that occur, then we could add the drop. So if you decide, for instance, okay, you're at risk, we don't want to necessarily give you the drops, or we make a mutual decision with the patient that we don't want to start drops, then you can say, well, we need to follow you very carefully then. Regardless, even whether you start the drops or not, you got to follow them carefully. But you have to be like, we'll do interval checks that are even shorter than what we normally would do. And then finally, I don't think it's unusual. I don't think it's bad. I think it's great to say, hey, I want to get another one of my colleagues to take a look at you. I think that we should be. This is a team effort. This is not a solo swimming event, right? This is a team effort, and I think that it takes a village to do things. And I think that if you have if I have a good colleague, I tend to some of my super smart colleagues at Stanford and locally, and I'll just send them to them and say, hey, what do you think? And they'll either agree or they'll say, yeah, I think this is reasonable, or they'll treat. I think that that's really the key. Good communication and good follow-up is really the key. And unfortunately, some of those things can fall through the cracks, which is unfortunate. You got to be really vigilant about that.
Are there any additional tests such as color vision, electrodiagnostics, gonioscopy that you would add to your workup to the patient?
Yeah, so obviously a full glaucoma workup can take, there are other things that we do, including we measure, as you pointed out, the corneal thickness, which is a risk factor, and it also helps us figure out whether the pressure measurement is artifactually low or high, depending on the thickness of the cornea, how we measure it. Gonioscopy, where obviously we're looking at the actual physical outflow chamber of the front part of the eye, and that's an anatomic description of whether the eye is a type of glaucoma risk that's a narrow angle versus an open angle, and that gonioscopy is critical. And by the way, OCT is an excellent technique also to confirm your gonioscopy findings. And then, in terms of physical exam, those are some of the main things that you do. One of the things we probably don't do enough of is pupillary testing. And I think that there's a lot of, we do it, and if you have what's called an afferent pupillary defect, or if there's a sluggishness to how your pupils respond when you shine the light on somebody, that's usually a sign of fairly advanced disease. But there's some really new techniques now. There's some new pupillometers, which I think would be very interesting to use, and that might be able to detect very subtle and early signs of optic nerve disease, glaucoma, and other things. And then, as you said, you can do these electrophysiology things. So like one of the things you can try doing is you can put like a contact lens, or you can put an electrode either on the cornea or on your skin, and then you can shine lights on the patient, and then you can actually record the electrical signal between their eye and their brain. And by doing that, between the front of the eye and the back of the eye, and then you can actually look and see what the response of the eye is, and then you can actually look at the response to the brain, and you can sometimes tease out through these electrophysiology techniques whether or not there's optic nerve disease. And those techniques are interesting. They're supporting casts. There's a lot of hype, tons of hype in that area right now in terms of can you diagnose early glaucoma with these techniques? And I think that those techniques are really fraught with a lot of artifactual data. And even though, they're the people in those fields, and I know some of the greats in that area who, unless you have a really good research grade, like what we call ERG, electroretinogram, electroretinography, unless you have a really good research grade, some of these commercial units just have too many artifactual data, and actually performing it with people, it's just a tricky measurement. It's a lot like my confocal microscope, very tricky to use. And so it's sometimes the data, you have to really know what you're doing. And then of course, like what you mentioned, that there are other new imaging devices that are coming out. I don't know, is there anything that you were thinking of that I missed?
No, I think you covered it. Some people are using color vision,
Oh yeah, color vision. Yeah.
Part of the supporting cast. I had the original pupil instrument, which measured.
Easier for you to say than me.
the Rapid X, and it was very good. For certain people, we pick up little subtle changes of the optic nerve. We actually picked up, unfortunately, a patient with a brain tumor with it. But then now there's a new Rapid X that has just come out that's a little bit easier to use and more patient friendly. So once I get back into the office, I'm excited to be using that again.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Let's switch to treatment and the different types of medication. the different categories of medications. Let's start with the prostaglandins. If you could talk about the different types of prostaglandins and how they work, because I know a lot of people that are watching this are probably taking latanoprost or Travatan or Lumigan or Vyzulta. If you could just make a comment about that classification of medications, the pros, the cons, the side effects.
Right. So the prostaglandins are a group of drops that actually act to inflame the eye. So it's really an interesting basis. But prostaglandins are there are receptors in our tissue, and the prostaglandins activate certain receptors in the cell membrane and in the tissue that actually induces an inflammatory response, which is kind of interesting, right? That you're giving a molecule that actually causes inflammation. And these inflaming drops, when you get inflammation, if you get a very low level of inflammation in the eye, it turns out that can decrease the pressure. Kind of interesting. And so these prostaglandins actually can, there are certain outflow tissues in our eye where when the inside of the eye makes the fluid that keeps the eye a sphere, and it keeps it keeps it a certain shape. And so we have these areas of our eye which are producing tissue or producing fluid, and it keeps the eye inflated, so to speak. But then this fluid needs to escape. And so this escape valve, and there's a 360-degree escape valve. It's kind of a ring of tissue called the trabecular meshwork. And it's in the front part of the eye, just at the edge of the iris. So just when your iris tissue, your pupil, just at the edge of your pupil, so you're not the pupil, the edge of the iris, which is the color part of your eye, just at that little area where where the white part of your eye and the color part of the eye meet. There's an outflow valve inside, or a meshwork, actually. It's more like a spongy material that releases the fluid. And this prostaglandins work not exactly in that meshwork, but it works in that area of the eye where it basically releases. It's actually a non-trabecular meshwork releasing drug. And so the prostaglandins work by probably creating a very low level of inflammation in that area, and it helps actually the fluid escape. And that exactly is the side effect, which is that you can inflame the eye. And a lot of people who use prostaglandins, latanoprost or Lumigan or whatever the drop of choice is, it causes the eye to get red. And it's interesting because prostaglandins, so the body does interesting things with inflammation, lots of interesting things, including one of the things that can happen when you inflame is you can get blood vessel growth. And that's often seen in the cornea. But the other thing that can happen is you can actually, when you get vascular engorgement or more blood, you can actually get growth of tissue. And one of the positive side effects of prostaglandin is that your eyelashes can get longer. And so the prostaglandins are used in used in cosmetic to make eyelashes get longer, if that's your choice. The old version of Lumigan used to really, the higher concentration of Lumigan would really get your eyelashes going like crazy. And the company changed Lumigan to a lower concentration, so it's actually a pretty good drop now in terms of less redness. But they took the original version, which caused all this exuberant eyelash growth, and they turned it into Latisse, which is now used to increase, you can apply it to the eyelashes. So the prostaglandins were, I think they came out in the early 90s. So it's amazing that that was a drop that was used. And there was our main drop. Prior to that, Timolol was which is a beta blocker. That was one of our first drops one of the newest drops that we had in like 20 or 30 years, which was in the 90s, the prostaglandins. Now, the other side effect of prostaglandins is that, as I said, not only does your eye get red, but there's this funny thing where the pigment in the color part of your eye actually can get darker. So the reason, actually, this is fascinating, Carrie, is one of the things. I just did a podcast actually on light sensitivity, and we were talking about like, why do people get light sensitive? and then it kind of evolved into the color of people's eyes. And one of the side effects of the prostaglandin is that it actually increases pigment in your eye. So one of the reason that somebody has a blue eye versus a brown eye is about the amount of pigment and the amount of light that gets absorbed in the iris, and then or how much gets reflected. And unfortunately, one of the side effects of the prostaglandins is that people who have blue eyes or bluish and green or hazel eyes can go to a darker eye. And I'll tell you, that's been a deal breaker for a few of my patients. Even though prostaglandin at the time was the #1 pressure lowering, medication, and it could save their vision, they were just adamant. They did not want. They'd rather go blind than have lose their color, go lose their blue eyes, and that's a true statement.
So you think I can put some of that on my head and maybe grow some hair?
If you do that, please let me know, because I'm going to invest in all those companies. Because you're going to need a lot.
So let's talk about what you alluded to, the second category of glaucoma medication, the beta blockers, the yellow cap. People are used to that at Tim Optic. Talk to us how that works, and what's the pros, the cons, the side effects.
Yeah, so Tim Optic was the gold standard for glaucoma, treatment. And I always want to keep coming back, to the point that while we lower the only thing we know that can reduce the progression of glaucoma is pressure. And that seems strange because I mentioned that pressure is not even in the definition of glaucoma, but it's a risk factor. And it's like reducing your blood pressure, your cholesterol. But Timol is a medication that reduces the production of the fluid. So the prostaglandins increase the outflow of the fluid that gets formed in your eye, and the beta blockers, or Timol, is actually a drop that's used. It reduces the amount of fluid production. So it blocks the production of the inside fluid of your eye, and that reduces the pressure. And interestingly enough, beta blocker, the Nobel Prize in chemistry and medicine, or in chemistry, was won for discovery of the structure of the a receptor for beta blockers, okay, the adrenergic receptors. So so the way it works is, as I said, it reduces the pressure, it reduces the production of fluid, and the side effects. The thing about beta blockers is that they can also affect other parts of your eye. Now, the beta blockers tend not to have as much ocular redness effects on the eye, and this will be a shocker to some of our listeners and our viewers, Carrie, is that eye drops can act systemically, and they can be very, very significant. And one of the things that happens is that when you use an eye drop, you can get that, even though it's a small amount, it can go into your systemic system. And not all eye drops go systemically, in other words, gets affected by the whole body because of the concentration of many drops. They don't have any systemic side effects, but in fact, Timol can. And one of the things about Timol, it's a beta blocker. So we use beta blockers all the time to lower our heart rate. And that can be a great thing if you have high blood pressure, or you have congestive heart failure, or you have other types of, atrial fibrillation, things like that. But, if you put an eye drop in that's Timol and you're not on a beta blocker, or you've never had one, you can significantly reduce your heart rate, and you can really drop your blood pressure. So it's really important to understand that that's one of the side effects. There are a lot of side effects. I'm not going to go through them all. But the other side effect that's significant is if you're an asthmatic or you have lung problems, it's really important because that can exacerbate lung disease. The other thing that is true is that beta blockers can make your diabetes get worse. So it can affect your glucose levels. So those are all really important side effects that you need to really keep in check when you start taking those.
What can we do to prevent systemic absorption of eye drops?
So there are some techniques where you can actually, so the reason that the main reasons that the drops cause side effects is that they go through the natural tear ducts. When we produce tears and we cry, or we put a drop in our eye, some of it flows onto our skin and goes nowhere. But some of it actually flows into these little tiny holes in your eyelid that then drains into the back of your throat. And all that tissue, both in your nose and your throat, has a tremendous amount of vasculature, and it just absorbs it right into the body, right into your bloodstream. And one of the things about your eyes that's interesting, Carrie, is that in terms of the systemic effects of some of these drops, is that it bypasses your liver, so you get an immediate effect. So, like for instance, if you have heart disease, some people are, chest pain, they'll put a little thing under your tongue, and like they'll put some sort of a nitro, like a nitro drop or something like that. And nitric oxide causes immediate vasodilation, but we'll get into that in a bit, because actually there's some aspect to that with glaucoma. But what happens is with the eye, it doesn't go through, like if you eat something, or when you eat food or you take an oral medicine, it goes through your liver, it gets processed. It takes a long time for that drug to have an effect on the body. But if you put it under your tongue, or for instance, a drop in your eye, it goes right into your bloodstream and you get immediate effects. So so this is a long answer to your question. I don't seem to get to the answer quick enough. I apologize. You can just clunk me on the head and say, hey, Fishman, get to the answer quicker. I just like talking about these things. But in the circuitous route, the way you can prevent the drop from minimizing it into your throat is obviously to close those little areas, the little punctal areas right here. Excuse me. And you can pinch them off with your fingers while you're putting the drop in, and then you can just wait, and that's a good way of preventing that.
So let's talk about the alpha-agonists, Alpha-gan, for example.
So Alpha-gan,
listeners are on Alpha-gan.
Yep.
Pros, the cons.
Yeah. So Alpha-gan's a great drop. It tends to have a lot less systemic effects. I like that. It doesn't have as much pressure lowering. It has a dual mechanism. It has both a pressure. It acts a little bit like the beta blockers, like Timolol, in that it reduces the production of fluid on the inside of the eye. But it also has another effect, which it also increases outflow. So those are two mechanisms that it does to reduce the pressure. And so it's a good drop. It's really what we consider more of a secondary, an add-on. So if you need lower pressure beyond what you get with the prostaglandin, you can add, or Timolol, you can add Alpha-gan. Alpha-gan, brimonidine is the other name for it. The thing about brimonidine, there's been some interesting studies showing brimonidine may have some neuroprotective effects on the optic nerve. So one of the things that when we talk about treatment, and hopefully we'll get into this, because we're talking about the optic nerve, it's not just pressure. There can be other factors. There are a lot of other factors other than just pressure. So if you have a drop that does other things, like for instance, supports the health of the optic nerve and actually prevents the optic nerve from dying at the biochemical level, that's a great thing you want to do. And there's been papers over the years kind of like touting Alpha-gan or brimonidine as a way to protect. It's a neuroprotectant of the optic nerve. And I mean, the data is not 100% on that, but that's the other mechanism that could be interesting about Alpha-gan. The side effects of Alpha-gan are generally well tolerated, but it can cause a tremendous allergy. There's the classic Alpha-gan allergy. So you can get like a red eye, like a conjunctivitis. And then it's amazing, you could be using Alpha-gan for years and all of a sudden you get a red eye. You always got to think, hey, this could be.
Yeah, it could blow up on you.
It can blow up. It's unclear why, for instance, people respond that way, why they're immune. It's an immune response. It's generally an immune response. And it's crazy. Like you could be on the job for 10 years and all of a sudden, bam. And probably has something to do with your gut. We'll get into that.
So let's go next to the carbonic anhydrase inhibitors. An example is Azop.
Yep. The Azop reduces the production of production of the fluid as well. So it's like a beta blocker. It reduces actually the production of the. It's sort of another way that the body can, that the drop will reduce the amount of fluid that's made by these cells in the eye.
Pros and cons.
So the pro is that it's just another mechanism. So if when you're trying to lower the pressure And again, I hate the idea of just chasing pressure. And I keep coming back to the point that you got to look at the optic nerve. You got to think about the mechanisms of disease and understand why the optic nerve is not just pressure, but if pressure seems to, if the health of the optic nerve seems to be responding to lower pressure, then it's just an alternative mechanism. And so if you're starting to run out of ways to lower the pressure, then it's just another mechanism, and it's a complementary mechanism. It does it. It's not a beta blocker. It's not doesn't work by the same mechanism as an alpha agonist or alpha inhibitor, and it works. It's just one more orthogonal mechanism to lower the pressure. And then the one thing that but again, you can have similar side effects where you can get a red eye. People who take that class of mechanisms, that class of molecules, they can get like a weird taste in their mouth, like a bitter, like a metallic taste. So those are some of the side effects. It's pretty well tolerated. Systemically, you don't get too many side effects from from azopt and from that mechanism. It's a good drop as a complementary drop. It tends to be a little bit irritating on people, the formulations, and it tends not to work as well. It doesn't have the same kind of efficacy as some of the other drops.
And let's talk about the newest class, the Rho-kinase inhibitors.
Right. Those are, the Rho-kinase. So, and also we'll talk about the nitric oxide addition as well.
Vyzulta, yes.
So, fascinatingly enough, for all the developments in ophthalmology, ophthalmic science, we had nothing. We had no new drops from 1990, the early 90s until about a year or two ago. So what is that, it's 25 years or something where we had absolutely no development. So for is that more? I guess is it 30 years? 90, yeah. But for almost 30 years, we had almost no new drops that really were a different class. So this new drop, the Rho-kinase inhibitor, is the first of its kind drop that actually acts on a different mechanism, which is that spongy trabecular meshwork mechanism that we talked about. So when the eye starts to relieve the pressure valve of the eye, so to speak, there are different mechanisms by which the fluid can get out. And the main one is through this mechanism called the trabecular meshwork, where the fluid goes into this ring of tissue that's, as I said, 360 degrees circumferential, right at the border between the edge of the color part of our eye and white part of our eye. That fluid goes out in that trabecular meshwork, and then that drains into our bloodstream. It drains into into the draining parts of our eye. And that's a brand new drop, and it's an interesting mechanism where it works at what's called the trabecular meshwork. And so it's a great new drop. The pros of it are, again, it's an orthogonal mechanism. It's unlike any other mechanism, so it can really it's actually a terrific drop. I've had really good success. We're just learning about some of the side effects of it. You can get a very red eye for some reason. It's not because it's acting on tissue in ways that we just don't necessarily know all the effects of it. One of the mechanisms is that by changing the collagen structure and so forth, it can change the vasculature. And so some people get a really red eye from it, like a beet red eye. It also seems to affect the cornea. One of the things that people see with the Rho-kinase inhibitor is that you can actually get these deposits. So actually the drug can actually deposit in your cornea. It's a term called verticillata. And you can get verticillata with other eye drops. You can also get it with systemic medicines. It's called a vortex keratopathy. That's another name for it. And that's a side effect that is we think completely benign, doesn't have any visual effect at all. Doesn't affect your vision, we don't think it changes anything, except you can see it on exam. So I don't really know if it's necessarily a side effect, but it's an effect that we see. And some people can respond really, as I said, they do really well, but the side effect profiles that these Rho-kinase inhibitors are uncomfortable drops. They tend to be tend to cause more irritation than some of the other drops that I've seen. But they are a dynamic drop, and it's a great new mechanism. And if you need to get your pressure down and you don't want to have surgery, it's a great option.
And the trade name is Rhopressa.
Right, Rhopressa, and then there's also they actually take this Rhopressa and they combine it with latanoprost, and you can actually have a combine drop. And one thing I want to mention is that all these drops that we talked about, like Alpha-agonist and Timolol, those are trade names. Timolol, bromonidine, Azopt, or these different drops. They have combination drops that can be very important. And so these combination drops, whereas you might have to take Timolol and Alpha-agonist, you can combine it and call it Combigan, or you can take basically take a drop like latanoprost that's combined with Rhopressa, and you can have a combination drop, which is really helpful.
Speaking of combination drops, Bausch & Lomb added to the prostaglandin a compound that increases nitric oxide, and the name of that drop is Vyzulta. How's your experience with that?
I have had great experience with Vyzulta. I've really liked Vyzulta. It doesn't seem to cause too much additional redness. In fact, it's one of the most mildest drops in that whole class. Excuse me. And so as you mentioned, it adds this nitric oxide. So nitric oxide is also the chemical is NO. In fact, the Nobel Prize was won for the discovery of nitric oxide in the 90s when I was actually doing neuroscience research as a Ph.D. guy. I remember that the Science magazine came out. They came out with the molecule of the year, and it was nitric oxide. Just say no. And it had tremendous effects. We know nitric oxide vasodilates blood vessels. Okay, so it vasodilates tissue, and that's one of the reasons why they think it works to increase outflow in the trabecular meshwork area and around the eye. And the other thing it does is their nitric oxide they think is a neuroprotectant. So not only does nitric oxide act at the level of the trabecular meshwork, but it may actually also have effects on the optic nerve itself. And I think you can't emphasize the importance, Carrie, of moving towards our understanding of not just lowering the pressure, which is really just a risk factor for glaucoma, but actually treating the glaucoma itself. Everything that we've talked about, every single drop we've talked about, other than possibly remonidine, all these drops are actually just lowering the pressure, and they're not actually affecting the nerve. And it may be that nitric oxide has a true neuroprotectant effect on the nerve, and that's what's nice about that. Sorry.
Patients often ask, is it really better to have a drop that's a real drop as opposed to a generic drop?
So the generics are in, not in every category. So some of these newer drops, which are still on patent, there are no generics for it. I have personally had anecdotal experiences where the generics just aren't as good. We've known for years, for instance, in some of the steroid drops, which obviously is not a good thing for most glaucoma patients. We can talk about that in part 3 if you ever want to. But the generic drops tend, even though they're supposed to have the same efficacy and they're supposed to be identical, they tend to. I've had many situations where the patient switched to a generic and their pressure went up, their pressure increased. So I don't know if that's the formulation, if it's because even though they don't necessarily have to be bioidentical, or they don't have, even though they're generic, they're not necessarily made the same way. They may not be the same exact molecule. They may have bioequivalency. So I don't know the details of what every generic has, but it's not always the same drop medicine. And we know that for many different formulations and drops. So the answer is that while I'm not a big fan of pharmacy, as you know, I would prefer to use non-pharmacologic treatments of everything. And, of course you have to use pharmacy, when you do. And so, but generally if there's a way of getting the actual branded name, it's better than resorting to a generic. But if you do go to a generic, one thing I will do is I will, especially when I first start treating somebody with glaucoma, often I'll prescribe a generic from the start, or if their insurance doesn't cover it. and then I just monitor it. So if I can get the appropriate response and pressure and side effect profile that looks good with the generic, then great, I'll use it, especially if it's cheaper. But ironically, some of the pharmacies and so forth, it turns out like sometimes a generic can be more expensive than the branded one. So it's just, we're living in a crazy world of pharmaceutical drops these days. It's just really frustrating the way the whole system works.
You know, and some of the branded companies actually make the generic, but there's 9, 10, 11 different companies that will make the generic medicine, and you really don't know what you're getting as a patient. There was a study done in India where they looked at latanoprost, a branded one versus generic, and the branded lowered the pressure 41%, where the generic only did 29%. So if you could go with branded, we're always probably better off, but many times the insurance company doesn't cover it, and typically the generic drug usually works pretty good. Maybe not quite as good as the branded in all cases, but in some cases it does. But with that being said, I want to thank Dr. Harvey Fishman for joining me today. You're a wealth of knowledge. Harvey, if somebody wants to learn more about you, how can they do that?
Thanks for asking, Kerry, and thank you. You are such a inspiration to me and the rest of the world in terms of really opening our eyes, no pun intended, about what eye disease is and how we can all help. But if you want to reach me, you can obviously find me on my website, www.fishmanvision.com. You can find me on Twitter at drfishman, drfishman. I have a new podcast called I Chat with Dr. Harv. I'll be starting a website called I Chat with Dr. Harv as well. And I also have an Instagram account called Fishman Vision, where sometimes I'll post neat videos and so forth. But that's how you reach me. As I said, Kerry, thank you so much for this. It's great being friends with you and colleagues, and you're a great guy, and you're really an inspiration to people who want to deal with their eye problems and understand their eye problems in a way that maybe they don't get explained, or they don't understand it from the traditional route. So thanks so much. You're a real inspiration.
Well, thanks, Harvey. And our next episode, we're going to talk about prevention. We didn't get to it as much today, where we're going to talk about exercise and green vegetables and green tea and different types of teas and meditation, and how that may be able to help decrease the progression of glaucoma, or decrease glaucoma and prevent it. So I'm Dr. Kerry Gelb for Open Your Eyes. Until next time, thank you very much.
Thanks, Kerry.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. so many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe for You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe for You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe for You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe for You.
And most importantly, the reason why I buy Safe for You is because it's safe for me and you.